deprivation therapy, they've got no libido, so sex isn't really of an issue for them, but this isn't true. So why does prostate cancer cause sexual effects? And there's a variety of reasons. Sexual dysfunction, in its widest sense, can result from neurological, vascular and hormonal effects, as well as the psychological effects of treatment and cancer. And this is because the neurovascular plexus is adherent to the prostate, so it's actually wrapped around it. And the plexus is really important for lots of things. It's important for the blood flow into the penis, so blood flow for erections and out of the penis, and also for the nerves that control erections, but also ejaculation and orgasm as well. So if we look at surgery in the first instance, we know that a large percentage of men will experience some degree of sexual dysfunction after surgery. And this is because inevitably when the prostate is removed, the cavernosal nerve will be damaged. And that might be because of cutting, direct trauma, because of stretching, because of heating, because of ischemia, sort of lack of blood, but also inflammation as well. And if the cavernosal nerve is damaged, this can lead to problems in the cavernosal smooth muscle. So you can get fibrosis or cell death. And that can have a direct response in terms of poor or absent erections, but also it can cause loss of penile length as well. For lots of men, if they have a nerve sparing technique, that damage may be temporary. But when we say temporary, that can be up to 1 to 2 years after treatment. So it's really important that men are aware of that. But as we know, if the cavernosal nerves are actually damaged irreparably during the surgery, then their spontaneous erections won't ever come back. But it's not all about erections. There are other consequences of surgery. When the prostate is removed, the seminal vesicles are removed as well, so men won't be able to ejaculate afterwards. And a poorly explained thing sometimes is that urinary leakage can have an impact on people's perception of their sexual function as well, particularly if that leakage happens during orgasm. Some men will report a change in the sensation of their orgasm after surgery. And for men who enjoy receptive anal sex, it can have a huge impact. The prostate is really important for sexual function for men that enjoy anal sex. And if you haven't got a prostate, that lack of sensation can be quite devastating. So if we look at surgery, there are some definite physical changes. So the penile shortening, the lack of ejaculation, the erection problems, urinary leakage, the change in sensation of orgasm are all physical changes that men may experience. But it's really important to remember all those emotional and psychosexual consequences as well. Low libido is something that lots of people with cancer will experience as a result of their diagnosis, their treatment, and their change in their sort of body image and sense of self. And the same with low mood. All that can have an impact on someone's sex life, but also their relationships as well. And we saw in Will's study that loss of confidence and that feeling less of a man can also have a huge psychosexual impact on somebody going forward. We often talk about the effect of the relationship. So if somebody has got a partner, that the sexual changes can have a huge effect on their relationship. But it's also not just a present relationship, it's also future relationships. Lots of our patients will be single or not in a relationship at the moment. And it can be really difficult for them to navigate how they will build new relationships in the future if their sexual function or their perception of themselves as a sexual being has changed. For radiotherapy, again, we can see effects from the neurological, vascular, and also hormonal structures. When someone has radiotherapy to the prostate, the structures at risk of damage are that neurovascular plexus again, but also the ejaculatory ducts and the bowel can all be affected. And if somebody has a wide radiotherapy field, for example, if they're having their regional lymph nodes treated, that injury can extend wider as well to the sacral nerve roots and to the pelvic floor. And radiotherapy can cause damage to the vascular structures and the penile tissue, causing problems in terms of the arterial flow into the penis. The corporal tissue can also become fibrosed as well, which means that men can develop venous leaks. So over time, and we often see this as a late effect of radiotherapy, men can develop erectile dysfunction in terms of finding it difficult to get an erection, but they can also find problems actually maintaining that rigidity as well. On top of that, the radiotherapy can also affect the nerves that are affecting both the ability to get an erection, but also the orgasm and ejaculation as well. So for men after radiotherapy, they can certainly have problems with erections, but there are, again, further consequences which may affect their sex life or their perception of themselves as sexual beings. So dry ejaculation or reduced ejaculation can happen because of the damage to the ejaculatory ducts during radiotherapy. Men can experience a change in the sensation of orgasm, again, because of that peripheral nerve damage. If the bowel is effective, again, for men that enjoy receptive anal sex, that sensitivity around the anus and in the rectum can make anal sex really painful, and again, may change their ability to have an erection. And it's important to say as well, for men that enjoy penetrative anal sex, the erection you need for that is often firmer than what you need for vaginal sex. So again, that can have an extra impact on men who have sex with men, or men that enjoy anal sex. And it's important to remember that for lots of our patients that are having radiotherapy, they'll also be having androgen deprivation therapy as well. So there's a kind of double effect there. And it's important to remember that on top of those physical things, there are also those psychosocial and emotional effects that we've discussed before around libido, mood and confidence and relationships. So androgen deprivation therapy, again, it may be given with radiotherapy. It may be given as a monotherapy, either in high-risk disease or advanced disease. And we know that androgen deprivation therapy causes a whole range of effects on someone's sex life, and that includes low libido, problems with erections, problems with ejaculation, either a delayed or absent orgasm or change in sensation of orgasm, and also that decrease in penile length and penile size, which can affect body image and confidence. We know that erectile dysfunction or sexual consequences occur in somewhere between 80 and 100% of men undergoing ADT. If they're on ADT for a short term, some of those effects will come back or will resolve after they stop treatment. But for men on long-term androgen deprivation therapy, that structural damage, the cavernosal smooth muscle, can result in complete irreversible ED, even if they stop treatment years down the line. So as we said, for some men, that's something that is in addition to their radiotherapy. For some men, it's their lifelong treatment. So let's just have a think. Although we were not specifically thinking about men with advanced prostate cancer, I think it's really important to mention them, because men with advanced prostate cancer are a growing population, because men with advanced prostate cancer are living longer. We've got a number of new life-extending treatments like androgen receptor targeted agents and chemotherapy, stereotactic radiotherapy. So these men are living on ADT and with the consequences of their treatment for a long time. So we've already said in the previous slides that sex is still an issue for men with advanced disease. And again, this study by Will asked men with advanced disease, what are you experiencing, and have you discussed it with any healthcare professionals? And you can see that in the light blue line that there are a whole range of things around erectile dysfunction, the penile changes, ejaculatory problems, arousal problems, etc. And also those more emotional side, things like loss of confidence and relationship problems that men are definitely experiencing on androgen deprivation therapy and the other treatments for advanced prostate cancer. But on top of that, if you look at the dark blue line, you can see that actually a surprisingly large number of men are not discussing that with their healthcare professionals. And that may be because we're not asking, or it may be that they think for various reasons that it's not something they can discuss through embarrassment, or because they think that we're not interested. And again, looking at this graph, you can see it's split between localized, locally advanced and advanced disease. And the men in this survey were asked, were you told everything you needed to know before treatment about sexual dysfunction? And you can see quite clearly that lots of men said they weren't told what they needed to know. And they also said that the support they received was not necessarily adequate. Interestingly, they also said some men felt that their information they received wasn't accurate, and that's really interesting. So they were told things that actually didn't marry up with what they experienced. Most men said they did feel that the information they received was appropriate to their sexuality, but of course, you know, the small percentage it didn't are potentially are gay and bisexual men that maybe didn't feel that the information they were given was tailored to their particular sexual practices. And again, it was disappointing to see that not all men understood the information they were given, even if they were giving it. And this really reflects previous work as well. So this is a really nice study, if you've got time to read it. It's a population-based study of men living in the UK, 18 to 42 months after diagnosis of prostate cancer. It was a postal survey looking at various functional outcomes of treatment, things like continence, bowel problems and sexual problems. And nearly 59,000 men responded. So we've got a really good population of men giving us their views on their experience. And looking particularly at the sexual effects, poor sexual function, we won't be surprised to say it was common. Around 81% of men reported poor sexual function. But I think what was really shocking in this was that over half of men were not offered any intervention to help with this. So put another way, only 44% of men that answered this survey said they were offered help for their sexual problems. So I think it's worth saying as well, just as we come to the end, that a lot of the sexual rehabilitation research and guidelines have focused very much on the restoration of erections after treatment. But as we've seen from the previous slides, sexual consequences are much wider than this. And sometimes if we really sort of overemphasize erectile rehabilitation at the expense of everything else, it can be counterproductive. For somebody for whom erection restoring isn't possible, or they're not interested in kind of things like vacuum pumps and injections that we'll be talking about later, setting that as a standard for kind of recovery is really unhelpful. It might make them feel even worse about themselves if they can't achieve what they feel they should be achieving. But most importantly, people have very different needs and concerns. Everyone's got different sex life. Everyone wants different things. And unless we understand the impact treatment is having on an individual, what's important to them in terms of their sexual practices and their relationships is very difficult to tailor the support they need to that. And some examples of this: if a man is particularly fond of oral sex, then things like climacturia, so leakage of urine at climax or on arousal, is going to be devastating for them. And as we said before, for men who have sex with men, there may be a much greater importance around ejaculation and the comfort around receptive sex, or the strength of the erection. So all these things are really important. But if we don't know what's important to someone, we can't then tailor our advice for them. And then, of course, on top of that, it's really important to absolutely embed the psychosocial impact. A lot of the work we do is not necessarily fixing things, but it's really helping people to adapt to change and maybe think about different ways of being sexually active and sexual beings and getting sexual pleasure. So to sum up, I think there's a number of things we can think about whilst we understand what might happen to men after prostate cancer treatment. I think understanding it is really important, and being very honest and open with men about what might happen to them after their treatment, and maybe moving away from just thinking about things in terms of erections and no erections and thinking wider about all their sexual impact that might happen. It's really important to ensure equity, to make sure that all men have got access to the support they need. To be honest and recognise that rehabilitation is really challenging for many reasons, not least of which not all the problems we can fix. It might be helpful to place less emphasis on erections and maybe think more about how people can adapt their sexual practices to encompass the changes that have happened to them, and how they can adapt to those changes in a healthy and productive way, and then tailor the erectile support to what they actually need, and to improve that holistic and psychosexual support, and not, again, just concentrate on the physical. So that's a kind of, hopefully, a scene setter. So I'm going to stop there. I think we're taking questions at the end. So I'm going to stop sharing and hand over to the next speaker. Thank you very much.
Thank you very much, Louise, with this excellent presentation. And you're right, we're taking questions at the end of the survey, of the webinar. The next speaker, I will introduce her. This is Mariet Lennaars. She's from Belgium, Hasselt. And she works as a nurse, as a prosthetic nurse, in patients with prostate cancer also, and patients who will receive the prosthesis for their erections. So Mariet, if you want to share your screen and your video, then I will give the floor to you.
Hello, everyone. Thank you for the introduction, Jeanette. As already told in the previous presentation, I'm going to talk about ED, the treatment options on sexual health after treatment for prostate cancer, but particularly on erectile function. First of all, I have no potential conflict of interest to report. And then again, in the previous presentation, it's already been told, there is a major impact of treatment for prostate cancer on sexual health of patients. And again, sexual health is more than only erectile function. We know that. But this is often seen as the same problem by patients and by doctors. So probably because it's the most common problem, but also from a medical point of view, doctors are mainly focused on erectile dysfunction and restoring erections. So it is important to take this into account, and as nurses, we can play an important role. We must pay attention to all sexual changes that can arise after the treatment, and we must discuss this with our patients. It is our job to raise this topic, because otherwise patients are often not aware of sexual changes that a treatment for prostate cancer entails, and other sexual problems or sexual changes can be libido reduction, a painful orgasm, but that's already told, reducing penile length, climacturia, and ejaculation. So do not neglect these sexual side effects, but take time with patients, discuss all the sexual changes before, during, and after the treatment for prostate cancer, and let the patient explain how important that sexual health is for him or is in his relationship, and try to figure out if he needs support or treatment for this problem. So in this presentation, I will talk about erectile dysfunction and the different treatment options for this problem. All the different treatment options for prostate cancer are all known to have a major impact on erectile function. So erectile dysfunction is the most common sexual disorder, and so that's the reason why I'm going to focus on this subject. Erectile dysfunction is defined as the persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. So in other words, we speak about ED when men have difficulties in achieving an erection or when they have problems with keeping the rigidity of the penis. Here you can see the management algorithm for erectile dysfunction from the European Association of Urology. And the first step is a diagnostic evaluation to discover the cause of the problem. But that's irrelevant, as in this situation, we know the cause of erectile dysfunction. So we go further to the second part, which is the management of the erectile dysfunction. This slide, once more, to point out the importance of good communication and sufficient information. It is very important to talk to your patients about sexual health. And again, start doing this before the treatment for prostate cancer starts. Furthermore, it is necessary to explain what differences they can expect and what sexual problems they may encounter, because it is unpleasant, because it's an unpleasant situation if the patient has to experience these changes himself. And it will also make a big difference in how they adapt to those changes. On the other hand, it is also important to listen to the patient's concerns and again to identify their needs and expectations. Then I will now briefly go over the different treatment options for erectile dysfunction one by one. As you can see, I used the guidelines of the European Association of Urology to build up this presentation. Here you can see the first-line treatment for erectile dysfunction. So regardless of the cause of ED, we always start with oral therapy with PDE5 inhibitors. So, I mean, there is no difference in treating erectile dysfunction after surgery or radiation. Are there any problems with achieving an erection? The first step will always be prescribing an oral medication. In some situations, you could question the effect of PDE5 inhibitors because if a patient has a non-nerve sparing radical prostatectomy, we expect no major effect of the medication, but we never know this in advance. So it's always the first step. But the patient's urological history is important to take into account, because if in such a situation you see no result, you can quickly move over to the next treatment option. A second thought should be if medication alone will be enough. So, for example, when a patient suffers from erectile dysfunction in combination with a libido loss, when he is also treated with ADT, I think in those cases it's really important to combine this medical treatment option with psychological and or sexuological therapy. Then, depending on the dose, this medication should be taken 1 hour before sexual activities, but there are also studies who recommend chronic daily use of low-dose PDE5 inhibitors as a part of a penile rehabilitation. So they assume that it has a positive effect on the recovery. But in all situations, it's really important to inform the patient properly so that he know the use of it, the working mechanism, and that he is taking it correctly. Oral medication is associated with many side effects, which arise regularly. So it's really important to keep this in mind and to you have to ask your patient about these side effects. In other words, is the patient comfortable with this therapy? And if not, if the side effects are too serious, another therapy can be considered. A vacuum device. A vacuum pump is a device that consists of a cylindrical tube connected to a vacuum pump and a constricting ring. So negative pressure is produced within the cylinder, which will draw blood into the penis to achieve an erection. Then the constricting ring is applied to the base of the penis so the patient can maintain the erection. With this device, I don't have many experience, so I have no patients who use this, but I think the first indication is very correct. It may be useful in patients with infrequent intercourses. Furthermore, it seems important to guide patients well, because I think this preparation, the bringing on the vacuum device, it's a time consuming and it's time consuming, and then the whole preparation makes the desire to have sex disappear sometimes. So in these situations, again, it can be necessary to combine this therapy with psychological therapy in the beginning. Once they gain dexterity in using the device, I think this could be a good solution for some people. You can use intraureteral alprostadil as an alternative first-line therapy in well-informed patients who do not wish to have intracavernous injections, or in patients who prefer a less invasive therapy. So that's the indication of the EAU, sorry. My experience is that a single use of this intraureteral alprostadil is rarely effective. So only for non-severe erectile dysfunction, it could be useful. And it's also quite expensive. One syringe is about 13 euros in Belgium. But we use it in our hospital sometimes after implantation of a penile implant. And then we do it to improve the result of the penile implant, or when the patient indicates that the glans is too small in relation to the length of the penis, because this product will cause engorgement of the glans. The most common side effect of this is urethral burning, excuse me, not bleeding, burning. But many people say that they have an unpleasant feeling in the urethra. Then intracavernous injection therapy. This is also an alternative first-line therapy in well-informed patients, or as a second-line therapy if other treatment options fail. The side effects can be pain, hematoma, and priapism. And again, it's very important to explain to the patients what priapism is. So information is always a really important thing in our guidance or in our consultation. In this case, it's really important that he is aware of this complication, that he know what it is, and that he can call help in time. Because we all know that the consequences can be serious if it's not treated within 6 hours. The damage is irreversible, and the patient needs to know this before start of therapy. Here on the image, you can see the right position of injection. And for nurses, it's quite obvious and not so difficult. But for a patient, it's a whole different story. So they are not used to give injections, and often injections into their penis scare them. So as a nurse, you need to instruct the patients well and demonstrate the technique at least once. In our hospital, excuse me, the doctor will prescribe the medication, and then the syringes are made in the hospital pharmacy, and the patients will bring them to the appointment. Then the doctor always starts with a low dose and then increases the dose until the perfect result is achieved. But during the appointment with the patients that we have, we give first of all, a comprehensive information, and thereafter we demonstrate and teach the patient how to inject. Then he has some syringes left over to use further at home, and then we see the patients back within a month at the same time as the doctor appointments, and then we can evaluate the results. So now we have discussed the first 4 treatment options, and it's really important in each situation to give the patient a comprehensive information, to explain the pros and the cons of each treatment option, and to discover patients' preferences. And then we come to a penile implant. Previously, a penile prosthesis was a third-line treatment option, but a couple of years ago, they adjusted the recommendation. And as you can see, they added a really important sentence based up on patients' preferences. Patients' participation, shared decision-making has become increasingly important, and that's the same thing in this case, because it's really important to listen what the patient wants. And this can make a big difference in the treatment plan. So no, if a patient is really convinced that a penile implant can be a solution for his problem, then you can offer this way earlier in the treatment process, where it used to be a third-line treatment option. Then the aim of a penile implant is to restore erectile function and to improve sexual and emotional health. So there are 2 different types of prosthesis. You have the malleable prosthesis, and you have the inflatable prosthesis. Within the inflatable, you have 2 subtypes, the 2-piece and the 3-piece inflatable penile prosthesis. And we always work with the 3-piece with the 3 pieces device, which consists obviously of 3 pieces. The reservoir is in the lower abdomen of the patient. Then you have 2 cylinders in the corpora cavernosa, and then you have the pump, and it's is in the scrotum. Here you can see the impact of a penile implant on sexuality, and the satisfaction score is really high after a penile implant. This study indicates that the patient also would prefer an earlier implantation. So if they are asked the patients, are you happy with your implant? The satisfaction was 83%. And then if they ask them, would you prefer an earlier implantation? 60% would say yes. And of those 60%, even the 50% would say, I would prefer it 5 years earlier. So it's a really big difference in sexual health for those men. Here again, so the highest patient satisfaction rates, if we speak of penile implants, then the inflatable penile implant has the highest patient satisfaction rates and also the lowest mechanical revision rate. I think it's really important to say that this is possibly not the most difficult surgery, but it's really important that it's done by a doctor who regularly does this. So in our hospital, we work with Professor Dr. Varendrigen, and he does about 150 implants yearly. So it's a really high number. So we see a lot of patients with penile implants, and I must say that they are really satisfied with the results. There is also a study now going on from the European Association of Urology. It's the Phoenix trial, and there they are trying to collect 1,000 patients to follow up. So now we are at year 2. The first patients we are following are now year 2, and we see that the satisfaction will rise after 3 months. So we did a first satisfaction questionnaire at 12 weeks after surgery, and then satisfaction scores were good, but not as high as there are on year 1 and year 2. And the complication rate is, at this point, really low, but that's normal because we are just 2 years started it. We just started about 2 years ago, so that's normal. So the conclusion, there are many treatment options for erectile dysfunction, but it is really important to discuss sexual health with your patient and not only talk about erectile dysfunction, but it is because it's really more than just having sexual intercourse. Excuse me. You have to pay attention to all sexual side effects, even if you are treating ED. And then it's really important to find out what the patient's needs are. Is there a question for help, or is it okay for them to let it this way? And if it's necessary, you can always refer your patient to another healthcare provider if it's needed, because you don't have to have the solution or an answer to each question. It's perfectly fine just to hear the patient and thereafter refer him to someone else. That's no problem. But it's really important to bring the subject on so they know that it's allowed, that it's okay to talk about, and they will not complain or how do you say it? They will not expect you to offer an answer to all questions. So thank you very much. And as already told, if there are questions, I will be happy to answer your questions after the last presentation.
Well, thank you very much, Marit, for this excellent presentation and overview of the different treatment options. As you mentioned, the questions will be answered at the end of the webinar, and we already have several questions, so there will be some time afterwards to answer them. Now I will introduce the last speaker. This is Rachel Dalton. She's a nurse, advanced nurse practitioner from Ireland, and now working at the St. James Hospital in Dublin. Previously, she worked at the hospital in Galway as a nurse specialized also in prostate cancer. and she will give an overview of the treatments options and the sexual dysfunction and psychological impacts of patients who are on androgen deprivation therapy. So the floor is yours, Rachel.
Thank you very much. 2 moments now and we'll get this organized. Excellent. So I hope everyone can hear me okay. So thank you very much, Jeanette. As mentioned, I'm Rachel Dalton. I'm an advanced nurse practitioner in urology now at St. James's Hospital in Dublin. And so this evening I want to focus a little bit on when it comes to sexual function, on the psychosocial and emotional impact that sexual dysfunction can have on patients and indeed on their partners as well. And so it would be a good idea if you had a little pen at the ready. So I'm going to introduce maybe some activities that might be helpful that you could chat to your patients about. I feel as nurses, we're in a really, really good position to talk to our patients about particularly how they're feeling in relation to sexual issues. We do build a really, really good relationship with our patients, and quite often they feel very, very comfortable in describing their issues to us. And so it's really helpful if we have some information and maybe some tips, advice, and some activities or range of helpful mechanisms that can support patients. As mentioned by previous speakers, we spoke about all the various different treatment options for sexual dysfunction. We focus a lot, of course, on the physical side of things in general, and it's really, really lovely to see that people are moving away just from focusing on an erection, which was predominantly something we talked about a lot when it comes to treating our side effects. There is probably no perfect fix when it comes to treating sexual dysfunction, but there are many different treatment options that we can support our patients in looking towards. What's really, really, really important to understand is we may find a treatment option that works to help our patients to achieve that erection that they want. But 50% of patients will discontinue an effective erectile function treatment if they're not adequately supported. And that's been shown to occur over the first year. So providing our patients with support in relation to whichever treatment modality works for them is really, really, really important. And again, bringing the focus away from just an erection itself and focusing on the couple and redirecting attention to sexual dysfunction as an umbrella term rather than erections is really, really important here. So now just to have a little think, what is our biggest sexual organ? Well, funnily enough, our brain controls so much of how we respond to how our sexual health responds in terms of erectile function, in terms of sexual function. And many, many, many things have an influence on a person's sexual health. Think about the person's sexual history, about their sexual experiences in the past. Have they been negative? Have they had any sexual trauma prior? A patient's mood, of course, that's going to directly affect their sexual function as well. And we know all those treatment options previously discussed at length, they can have and do have an impact on a patient's mood, their desire for sexual function, their libido, interest, all of these things. And indeed, of course, many medications, particularly androgen deprivation therapy and its effect on the mood and depressive symptoms too. Think about the patient's general health as well. So that's going to have an effect also, particularly when it comes to other etiologies and health conditions. And very, very importantly as well, when we are talking about sexual function for patients, their partner is so important as well to become or to be involved within this discussion. So again, we're speaking, of course, of male and female partners here. So it's important to remember that in general, so leaving prostate cancer aside, in general, patients who or men and women at some point in their life will have an issue with sexual dysfunction. So we know about 30% of men in general may have an issue with sexual dysfunction over their lifetime. And for females, that's considerably increased, with probably about 40 to 45% of females demonstrating some sexual dysfunction issue over their lifetime. We know sexual behavior, sexual function, it's really, really complex. So yes, again, the physical aspect of sexual function, the erection being extremely important. But I think it's really, really important when we're looking after our patients to focus on using a model of care that incorporates not just the physical fix, but looks at the psychological aspects and looks at the social aspects that may influence a person's sexual behavior. Again, many of these issues were already mentioned when it comes to our prostate men, but what's really important again is to use this a model, rather not just this one, that focuses or thinks about all of these variables. So we're again looking at a patient who's had treatment that may have body compositional changes, genital shrinkage, so on and so forth. From a psychological point of view, and again mentioned before, issues with masculinity, self-image, body image, your thoughts and emotions, and indeed behaviors and how they can affect the patient as well. Your social environment and context. Again, we're talking here about relational and changes in relationships and roles. Again, role shifts from husband and partner to patient and caregiver. So all of this is going on in the background, and so you can only imagine how a person may feel in this situation. So what I want everyone to do, I quite like to put myself in a person's shoes, because I feel it helps me understand a little bit more how a person can feel. So how do you think a person with sexual dysfunction, how do you think that can make a person feel? Be it from a female perspective, from a male perspective. Just consider that just for a couple of moments. And maybe even write down one or two little tips. I'm conscious of time. So, of course, we know for the individual themselves, it can make them feel stressed, worried, and it'll make them feel quite anxious, of course, emasculated, worthless. This comes across quite frequently in the literature. And again, considering the partner as well, how are they feeling? Are they feeling rejected? Is there a sense of frustration there? Are they feeling unloved? All of these things are cropping up across the literature as components to how people are feeling when there is that issue of sexual dysfunction in a relationship. And what's really, really important, and considering the percentages I had mentioned there at the start, is to maybe consider to try and normalize aspect of sexual dysfunction, particularly as a person gets to later stages in life, or indeed when they undergo certain treatments for cancer. So sexual dysfunction is common. Quote the figures, mention 30% of men have this issue, mention 45% of women will. And so think about then highlighting the prevalence, as I mentioned, but redefining our preconceived ideas about what normal sex is. And again, as Louisa correctly mentioned at the start, this is going to be different for absolutely everyone. And sometimes that can be hard. We're going to have to look at what I suppose that person thinks normal sex is, and maybe look at reconfiguring that a little bit. Again, we're moving away from a focus on penetrative sex to more affection. I think it's important to think about a sexual response cycle just for a moment, and I do like highlighting this for a couple of reasons. This particular response cycle is actually used a lot more commonly for females, but is important as well, and used for male sexual function as well. What I do want to highlight here is quite often, and particularly men who have had treatments for prostate cancer, and indeed those men who have had therapies such as androgen deprivation therapy, most of those men will not have that spontaneous desire for sexual function anymore. And so that's really, really important to remember. So their role will change a little bit. Quite often the male may be that person in the relationship who initiates the sexual function, the sexual act. But the important thing to reiterate as a nurse within a service is that a desire for sexual function can occur along many different areas of the sexual response cycle continuum. So yes, motivations for sex, probably, you think about their positive, negative. So emotional intimacy being a positive, sexual stimuli, you're talking about kissing, touch. And again, whilst we're on this point, I do like to highlight with people, and I think this might come up across the presentation as well, something that's really, really important when you're talking to couples about sexual function is knowing what knowing what behavior in terms of closeness can subsequently lead to a sexual response as opposed to an emotional connection or seeking intimacy. So having that conversation and having that communication with your patient as well is really, really important, so that they know that, as we'll speak about in a moment, how important communicating to your loved one is about all of these bits and pieces. The next thing, which is really important, context in mind. So here we're thinking about the context, think about the environment. Really, really important to have an appropriate environment in mind when it comes to sexual function. And that environment, being very different from person to person, of course, but an environment where a person feels safe, feels comfortable, and perhaps that might mean you might need to plan that. So that's something we'll talk about in a few moments as well. Now, moving along here. Sorry, it's decided to stop. Okay, so considering all the components within the sexual response cycle, I like to talk about various different psychosocial interventions that I suppose we could refer our patients to, or we could encourage our patients to think about. One of the first things I think for individuals particularly is people have a sexual history before they have prostate cancer, and they bring with them both positive and negative experiences along their journey and continuum. And importantly, very important to remember, is a person will remember and will bring from their past or their most recent sexual experience that feeling with them. So if that is a negative feeling, that's going to come with them along the continuum and come with them through other interactions relating to sexual function. So that's firstly really important to remember. The second thing to remember is patients and their history may have some trauma related to that and might need some counselling on their own, firstly, to maybe look at their preconceived ideas about what sex is, what sex means, and maybe break that down a little bit. Second to that, then, really, really important if a patient is in a relationship, indeed, to focus that counselling behaviour on the couple itself. And interventions have been proven to work better if they're couple focused and include a more supportive counselling environment and education. The third really, really important point is to set expectations. So when we're talking about all of these different possible treatment options, you really need to counsel your patients on the fact that most of these things will fail now and again, and that's okay. Sexual interaction and sex is about having fun, about enjoying the moment, about being close to each other. Move away from the idea that only sex can be successful if a man achieves an erection. That idea of sexual function only being when a man achieves the erection as being a successful interaction needs to change. And thinking about talking to your patients about that too can be helpful. So we've moved on here to section 4. I'm getting ahead of myself. So moving away from pass fail mentality and broadening targets. So patients may like to think about their sexual repertoire and what is there currently, and maybe they can educate themselves on other sexual practices that they might like to include within their repertoire as well. One very important thing, and I talk to our patients about this, is to avoid discouragement if challenges arise, and they will arise. So we've considered those components. What's next? Well, there's a little bit of, again, as I said, fun involved in trying to think about where things can go from a sexual function point of view. One thing that's important is, in most instances, sexual function or sexual activity will need to be planned. So men are no longer cued by those spontaneous sexual urges. So they do need to get planning. And so think about maybe when sexual activity, when it feels right for you. Again, the patient as well may feel that little bit tired, maybe towards the evening time, they're more fatigued, and maybe it works better to plan engaging in sexual activity earlier in the day. Having that conversation is important. Being flexible and think about, again, as I mentioned, other different kinds of intimacy and different kinds of sexual activities you can include, or a patient can include in their sexual repertoire. So thinking outside the box, and again, moving away from an idea that penetrative sex is the only way you can be intimate. Again, involving or bringing education into things is important here. So participating in educational interventions to assist in adjusting. Cognitive behavioral therapy as well can be helpful for patients and their partners. Again, that can identify ways in, identify triggers or past behaviors, and psychosocial therapy as well. If that's available within your service, great. I know there are other services privately, which can be really, really important. And that therapy, again, helping patients to revise their perspectives around what's normal sex and revising their expectations as well. And again, moving from a focus of climax to affection. When we think about activities, again, thinking about connecting in other ways, thinking about, maybe looking at date night as opposed, to plan moments again together. Maybe looking at a new hobby together, moving again away from just focusing on sexual desire, and importantly, not forgetting the importance of closeness, connection, and intimacy in other ways. I think it's really, really important to ask patients to consider a few things, and communication is extremely important. Again, as we've talked about, there's so many treatment options out there. Some of them may work and some of them may not, but talking to your partner about what you're going through. And again, there's various different ways, of course, you can do this, whatever works for you in your relationship is best, of course. But one thing that we know is that being honest is really, really important from the get-go. Patients and loved ones find it easier to adjust to a loss of a sexual relationship if they understand why that is happening. And again, maybe we should change that a little bit to a change in a sexual relationship, because people can feel abandoned if they don't understand what's happening. Is it me? Have I done something wrong? Women particularly can feel a lot more distressed in this situation, so the research may suggest anyway. Really, really important, I mentioned earlier, talk about what behavior is linked to closeness versus sexual intimacy. So maybe holding hands, this is us being close, this is us being intimate. Maybe you touch in a certain way, which means let's try and be sexually active this evening. So think about having that chat so that each person feels very much safe. Suppressing emotions to protect each other. So this can be something that patients can do, again, avoiding that open discussion. So this can only lead to further frustration in this regard. Being open and honest about how you feel, inability again to communicate can aggravate that anxiety. So before I get to that, I actually did forget to mention what I like to ask patients to do a timetable of their week. So if you have a patient and their partner who come in and they're thinking about, they're talking about their sexual dysfunction and issues surrounding it, I ask patients to think about your week. Think about what you do on a day-to-day basis. Write down all the time you dedicate to your social aspect of your life, your family. Write down what you dedicate to work, what you dedicate to your friends and your alone time, and maybe consider what time you dedicate to your sexual function. Have a little look at that weekly timetable. What's missing? Maybe there's a lot of time being dedicated to one thing, and that's normal. Priorities are going to change over the course of a person's lifetime. Then maybe think about a week or a time in your life and you had more of, I suppose, a satisfactory sexual activity. What way did that look different? I know, bearing in mind, obviously, things can change from a health perspective, but are there other things that maybe have taken priority that really you need to maybe consider that you could take a step back from? And so that can be helpful as well. Again, Louisa is on the program as well for the androgen deprivation therapy patients, but we talk about action planning there and goal setting. And I always like patients to write things down, because I feel if you write down what you would like to do, think about how you're going to do it, and importantly, what might get in the way. I think it's really important then, at the very least, to get that conversation going and starting. So again, example here, this is from the ADT, Life on ADT program. Action plan, writing down, communicating more when and how you're going to do it and with who, being accountable, so having someone to do these things with, and writing down why it's important. Again, the very act of writing these things down is in itself a proactive approach. So the ADT program, again, I'll put a little plug in here. If anyone has patients who would like to join, they can look at the lifeonadt.com. There's so much information to talk about when it comes to psychosocial, emotional aspects for these patients. And I've ran over time now, and I'm sorry about that. So I might just stop it there, and if people have questions, I'm happy to answer if I can.
Thank you very much, Rachel, for this excellent overview of on the sexual function and the psychological impact of the treatment of prostate cancer. First, before we start with the questions, I want to thank Ipsen for sponsoring this webinar and make it possible to give this excellent webinar. So thank you very much. Now I want to go on to the questions. There are some questions in the Q&A, and some of them have already been answered. Let's start on the top of the questions which are still open. First question is from Corinne Tillier, and it's a question mostly to Marit. she asks, what do you think that the nurse can play as a role in sexual health? Since you work in Belgium, Corinne says that the function of a nurse practitioner, as we know in the Netherlands, does not exist in Belgium yet. So how can you play a role as a urology nurse in Belgium to assist patients with the treatment of sexual dysfunction and prostate cancer?
I think that's possible because in our hospital we work with 3 nurses on the outpatient clinic, and we don't assist the doctor during his consultation. We have our own consultation room, and we see our patients independently. So we counsel the patients before prostate cancer treatment, and then we bring up the item sexual health, and also we see the patients back 4 weeks after the surgery, and then we can also ask them about the side effects. And it's not only incontinence, but it's also sexual changes. We repeat it again because mostly they didn't hear it preoperatively, so we repeat again, what can the changes be? Did they have sexual intercourse yet, or did they try it? Did they can have an orgasm? And all. I think it's possible for us because it's not a nurse practitioner, but we know it as a nurse consultant, or I know how you say it, but it's possible here in our hospital, and I think in other hospitals in Belgium it's the same.
Okay, thank you. That's an excellent example, and good to hear that it's possible in other hospitals in Belgium also. Corinne has also another question. Not sure who is going to answer that, but in case of side effects of PDE5 inhibitor, can you consider to reduce the dose or instead jumping to another treatment or another medication? Marie, do you want to say something about it? Otherwise, I can do also.
Yeah, we first try to motivate them to continue because the side effects often diminish after a while. So if it's possible, we try to encourage them to hold on. And if it's not improving, then you can lower the dose, but then maybe it will affect the erection. So that's a bit questionable. But those cases, it's always in consultation with our doctor. We don't do it on our own because we don't have the right in Belgium to prescribe medication.
Yeah, I think we do about the same. I sometimes advise them also to start with another brand of the PDE5 inhibitors. There are 4 kind of PDE5 inhibitors. And my experience is that when they have side effects from, for example, sildenafil, they can jump to vardenafil or the tadalafil, and then they don't experience that kind of side effects. So that's also another possibility.
Yeah. Or try the daily low dose of one of the options. Tadalafil 5 milligrams each day. Sorry.
Yeah, that's correct.
Often has a better effect than just to take it in time.
Yeah, but sometimes it's not enough. Then you can higher the dose again to 10 or 20 milligrams.
Yeah.
Another question from Corinne. And thank you for the questions, Corinne. She says that in her hospital they have a penile rehabilitation program after nerve-sparing prostatectomy. I know you have, Corinne. As soon as possible to start with PDE5 inhibitors, for example, sildenafil, in combination with a vacuum device. Do one of you have the experience of starting the combination early after prostatectomy, say 6 weeks after surgery in your hospital?
No, we do. Yeah, we don't. We start medication really soon, about 2 weeks after surgery, but we don't combine it with the vacuum device. But I'm really curious about the results. So maybe in the future we will do it.
That's certainly what we do, Jeanette. We start people that are on PD5 straight away, unless they've had a non-nerve spare, and then vacuum from 6 weeks. Really, it's about the idea behind it, the theory behind it, is to just keep the corpora oxygenated, to keep the tissues stretched, try and reduce some of that penile shortening. And I think somebody in the comments mentioned that as well as another good reason to look at the vacuum pump. Also, obviously, for some men, if erections are important to them, it does allow them to get an erection whilst the recovery is happening. So yeah, all our patients are prescribed a vacuum pump after surgery.
Yeah. And does the insurance company provide or pay for the vacuum device in the UK?
We don't, we're NHS, but NHS does, yeah.
So patients have to pay that themselves, yeah.
No,
they don't.
They get it on the NHS, yeah.
Ah, okay. Yeah, in the Netherlands,
So
they have to pay it themselves.
It's different in Ireland. Patients are started on a rehabilitation program, and our andrologist in Dublin actually would encourage patients, even who have had non-nerve sparing surgery, to start on PD5 inhibitors, as there is seem to be evidence suggesting that there's a small role there for rehabilitation. And when it comes to vacuum pumps, then if patients fail PD5,
You froze, Rachel. I think I will take over. In the Netherlands, the situation is a bit different. It's not paid by the
inhibitors would like to
insurance.
explore their options, then they're referred. These patients have to pay.
Yeah, and the Netherlands have to pay it themselves also, both for the tablets and the vacuum device. So it's not that common, I think, all over the Netherlands. And Corinne, I know your hospital is advising that. And they will be starting a research about the effect of the PD5 inhibitors in the vacuum device. And we also will joining the research from the hospital Corinne is working in my hospital. So I hope this will give another overview and other results of the effects of the vacuum device and the PD5 inhibitors. Let's go to the next question. That's from someone else. And that's the question is about the recommendation of the management of erectile dysfunction for someone with a cardiac history. And I think that's a completely different course of erectile dysfunction, not caused by the prostatectomy or androgen deprivation therapy. In general, the advices and the management for erectile dysfunction for other causes like cardiac history, as Marit also mentioned, is starting with first doing a history of the patient, and then start with the first line treatment like the PD5 inhibitors, and if that doesn't work, then go on with second line or third line treatments like the vacuum device or the injections, or afterward as a third line the erectile prosthesis. I think, Marit, do you agree with that?
Yeah, but if a patient cannot have oral medication, yeah, it's also in our hospital in consultation with the doctor, and we try other treatment options, and the EAU suggests vacuum pump. So maybe that should be the answer.
Yeah, certainly. If they're not allowed to have the PD5 inhibitors, then you start with the second line immediately. Yeah.
I think it's important as well. It depends obviously on the degree of cardiac history and issue. If a patient if it's appropriate for them to engage in sexual activity in the first place, because we know that would put a lot of pressure on their heart. So it's important to have that knowledge as well.
Yeah, exactly. Then another question from Sally Wildeman, a Dutch nurse. I would like to mention that the vacuum device can also be used to improve the blood supply, as is mentioned before in the presentations, to the patient to maintain the length. So that's only a remark on this, which is also mentioned by Marit. And Louise, I think you mentioned it also. As a treatment for rehabilitation of the penile length and blood supply. Then Corinne also mentions something about the insurance companies in the Netherlands and other countries, which she asks if the penile prosthesis will be insured not just after the second line treatment, but also after first-line treatment, so without vacuum device or injections in other countries than the Netherlands, because in the Netherlands it's rather strict. It's only insured after they tried one of the options in second-line treatment. Do you know how it is in Ireland, Rachel?
Well, patients can, you see, if they come in on under a public into a public hospital, they'd just be on a longer waiting list. So they won't necessarily have to pay, but they will be on a waiting list. We have three andrologists only in the country, so waiting lists publicly are quite long, and then privately, I suppose it depends on the patient's insurance cover.
What is the waiting time? What is the waiting time
in Ireland?
Yes.
Oh, for public patient, I daren't hazard a guess that I don't know. I honestly don't know. I think it could be 2 years for some people publicly, at least. That may not be right. Don't quote me on that. But the last time I heard.
Yeah.
Okay. That's a long time.
Yeah. And Louise, is it similar to Ireland and the UK?
I don't think there's any. So prosthesis are done in specialist centres. There's regional centres. We are one at Guy's. I don't think there's any. As far as I know, I could be wrong. I don't think there's any rules that say they can't have one. I mean, the general good practice would be to encourage people to try all options before going for prosthesis, just because of the irreversibility of it. But there are no kind of particular rules to say that somebody has to do X, Y, and Z, because obviously there's lots of other reasons, like psychological, why people might not want to do certain things. In terms of wait lists, I think pre-COVID and post-COVID were in very different worlds. Post-COVID are elective recovery plans of HITs, things like andrology hard. So I think our wait lists are quite big at the moment. Pre-COVID, they probably weren't quite as bad.
Yeah. And the next question from someone else. What is the life expectancy of a penile implant, especially when the patient is rather young, like 50 years old, for example? Marit, what do you take for the general life expectancy of a penile implant?
Yeah, the penile implant has a life expectancy about 8 to 12 years, but we also have patients in 50s who get an implant, and then we just wait until the device is broken or defect, and then we just then the doctor just replace the thing that is broken. So a revision is no problem. It's sometimes easier than the first implantation, and if it's the pump, he just switches the pump. If it is a cylinder that is broken, and then you don't have a closed system, then it cannot work. Then you just remove the old one and put in a new cylinder. So it depends on the problem, and it just can be fixed. But the only disadvantage is it means a surgery for the patient.
Yeah, exactly. Then Corinne has also a special question to Rachel. Rachel, can you please answer them in the Q&As? And we'll move on to the next question. That's also a question to Louisa, but maybe we can discuss this here, or at least there are some other questions. Louisa, would you please answer that question also in the Q&A? Then we go to the last two questions. Are the patients included during the discussion regarding ED treatment? Are the partners included during discussion with ED treatments? Rachel or Marit, can you say something about it?
Sorry, I didn't get that. I was trying to find the question you want me to answer.
Oh, okay.
In the Q&A.
You can do it also afterwards. The question here is, are partners also included in the discussion about the ED treatments with the patients in your outpatient clinic?
Absolutely. Yeah, certainly. For myself and Anna, the prostate cancer AMP in James's, run clinics for our patients for both benign and prostate cancer patients for erectile dysfunction, sexual dysfunction. We advise patients to always, if they can, bring a partner with them. Because it is a couple's treatment. There are so many variables that needs to be discussed. It can take time. It can take multiple visits. They can be 2-hour-long appointments, so you need to be prepared. So absolutely, we'd actively encourage, and I'm sure everyone would do that if they could.
Yeah, I agree totally with you. And the last question. Someone who says, I've heard of some sites teaching intracavernosal injections to patients pre-operatively. Does any one of you have experience with that? So teaching the intracavernosal injections before the prostatic surgery, before the prostatectomy, I mean.
No, we talk to them about it. It's part of our pre-op education seminar, but we don't individually teach them to do it. That's done afterwards if they need it. All our prostatectomy patients are followed up in a functional clinic based on kind of PROMs, questionnaires, and then with particular proactive support for their continence and erectile dysfunction. So they'll be referred for injections if and when they need it from there for teaching. And
Marit, is it the same in your hospital?
No, we do not encourage them. And
not before surgery?
No, never.
No. Yeah, we do neither. We only tell them about the injections or give them lessons to how to use it afterwards. For Rachel, is it for you the same?
Absolutely, yeah. Post-operatively, after, for the most part, they've tried other options as well.
Yeah. So that was the last question from the Q&As. I want to thank all the participants for listening to the webinar and enjoying it. And again, I want to thank Ipsen for sponsoring and making this webinar financially possible. So I want to wish you all a pleasant evening tonight and hopefully see you in Paris next year. Thank you very much. Goodbye.